Hello everyone, today I'm excited to present an educational module focused on a critical question in obstetric anesthesia. In elective cesarean patients, does an ESP block with spinal anesthesia compared to a TAP block with spinal anesthesia enhance early ambulation and recovery post-operatively? Thank you for your time and attention, and let's dive right in. Some of the learning goals for this educational module is to look how an ESP block is effective, how it compares in providing effective analgesia, looking at its safety profile to understand the risk and benefits associated with ESP blocks, its increased analgesic benefits, improved patient outcomes, and lastly, the module aims to promote evidence-based practice changes at your facility, supporting improved standards of care for cesarean section patients. Effective pain management remains a challenge in patients undergoing C-sections. Acute pain, if not adequately controlled, progresses to persistent pain, contributing to peripheral and central desensitization. This not only prolongs discomfort, but it complicates recovery. Traditionally, opioids have been a primary method for managing post-C-section pain. However, it presents several risks, including respiratory depression, limited maternal ambulation, and an increased risk for falls. The ongoing opioid crisis further emphasizes the need to reduce opioid reliance. In obstetric care, opioid exposure impacts the newborn, contributing to sedation and affecting feeding and bonding. Acetaminophen is often employed as an adjunct for pain control, but its use can be limited due to issues such as coagulopathy and liver dysfunction. And while spinal anesthesia is a cornerstone of cesarean section analgesia, it has limitations as well. It's short in duration and insufficient for post-operative pain control. Now let's look at the background to the problem. Managing pain after a cesarean section presents unique challenges. Cesarean sections are major abdominal surgeries that often result in longer recovery times compared to vaginal deliveries. This procedure can cause significant discomfort, with some patients describing the pain as unbearable. While spinal anesthesia is commonly used, it is often insufficient for prolonged postoperative pain control, necessitating additional interventions. Pharmacologic pain management in C-sections can be particularly complex. Providers must balance effective pain relief with minimizing medication effects on the newborn. If poorly managed, acute post-cesarean pain can lead to persistent pain conditions. This is associated with serious consequences, including postpartum depression, maternal health deterioration, and poor neonatal care. In some cases, patients may develop hyperalgesia or chronic pain syndromes, further complicating their recovery. Addressing these challenges underscores the need for improved regional anesthesia techniques that enhance pain control, promote faster recovery, and improve overall maternal and neonatal outcomes. Did you know that 1 in 4 children born in the US is delivered through a surgical procedure? That's approximately 25% of all births. In fact, there are more than 25 million cesarean sections performed globally every year. This trend is particularly evident in the United States, where the rate of C-sections continues to rise. In fact, the US has one of the highest rates of C-sections in the world, but it's not just the US. China has an even higher rate of cesarean deliveries, which reflects a growing trend in countries worldwide. C-sections are predominantly performed on younger females, and while these surgeries are often seen as a necessary procedure for the safety of the mother and the child, they come at their own set of challenges. Many women expect a quick recovery, often aiming to return to their normal daily activities shortly after the procedure. However, it's important to recognize that a cesarean section is a major abdominal surgery that requires adequate rest, care, and attention to ensure a full recovery. The clinical significance of these challenges is that untreated pain in obstetrics, particularly after a C-section, can lead to significant challenges. Fear of maternal and neonatal adverse effects often delays early ambulation, breastfeeding, and recovery, reducing patient satisfaction. Chronic pain syndromes develop, with C-section contributing to postpartum hyperalgesia and persistent pain. Additionally, lipid-soluble drugs like opioids can cross into breast milk, leading to newborn sedation. Delayed recovery also places strain on labor and delivery units, contributing to nurse burnout. Addressing pain management is crucial for both maternal well-being and the efficiency of healthcare teams. Let's look at the mechanism for an ESP block. It is an interfacial plane block performed underneath the erector spinae muscle, typically at the T9 spinous process, either laterally or with the patient in a sitting position. This block targets the spinal nerve ventral and dorsal rami by injecting a local anesthetic, usually 15 to 20 mL of a 0.25 to 0.5% bupivacaine or a 0.2% ropivacaine on each side. The local anesthetic diffuses into the paravertebral spaces, providing a wide range of analgesic coverage, typically extending 3 to 4 vertebral levels cranially or caudally. The analgesic effects of this block can last for at least half a day, making it an effective option for managing postoperative pain. This technique offers significant pain relief while avoiding the need for systemic opioids, providing both maternal and neonatal safety. Let's look at an ESP block. It is performed with 15 to 20 mL of 0.25 to 0.5% bupivacaine or a 0.2% ropivacaine on each side, providing superior duration and analgesic potency compared to a TAP block. Studies have shown that the ESP block group consistently experiences lower pain scores at rest and during movement, reduced opioid consumption, and greater patient satisfaction. The superior analgesia mitigates the need for opioids and is especially important since this can be transferred through the breast milk, potentially affecting the neonate. The risk of local anesthetic toxicity are rare with an ESP block unless high doses are used. This makes the ESP block an effective, safer option for managing postoperative pain in cesarean patients. Here we could see the wide dermatomal spread for an ESP block. Now let's compare an ESP block to a TAP block. An ESP block provides both somatic and visceral pain relief. It is far from nearby major organs with an increased safety profile, longer duration of a block, higher patient satisfaction, lower pain scores, and decreased need for rescue analgesia when compared to a TAP block. An ESP block provides patient outcomes similar to a TAP block, but with superior analgesia spread and duration. A TAP block is performed for abdominal surgeries and is an alternative to epidural analgesia. However, it does not provide visceral pain relief. A TAP block's limited local anesthetic spread is a huge disadvantage in the obstetric population. A multimodal approach is recommended as first-line therapy for managing postpartum pain. Effectively treating pain is crucial as unmanaged pain can disrupt breastfeeding, which is essential for both maternal and neonatal health. By utilizing a multimodal approach, we can improve both mother and baby outcomes by reducing hospital stays and promoting faster recovery. This approach not only enhances recovery but also improves patient satisfaction and accelerates the return to normal daily activities. Opioid-sparing techniques are particularly important as opioids can be transferred from the mother's milk to the newborn, leading to sedation and respiratory depression. Reducing opioids use helps mitigate these risks, ensuring a safer environment for both the mother and the baby. Ultimately, implementing these strategies leads to better overall outcomes, promoting a smoother recovery, enhancing the well-being of both mother and child. We've arrived at the end of the educational module. Let's look at some key take-home points. First, it is best to avoid narcotics in the obstetric population whenever possible. When comparing the ESP block to the TAP block, the ESP block offers superior, longer-lasting pain relief. The ESP block targets the erector spinae muscles, effectively inhibiting somatic pain and provides analgesia by blocking both the ventral and dorsal rami of spinal nerves, a benefit you do not see with the TAP block. The ESP block's ability to spread transforaminally and epidurally results in wider dermatomal analgesia, covering from T1 to L3, making it superior to the TAP block. The ESP block can also be performed in both lateral and sitting positions, whereas the TAP block requires the patient to be supine. By choosing the right pain management technique, we can significantly improve both maternal and neonatal outcomes. Thank you so much for joining my educational module, and I hope you've enjoyed.